if you look at data in patients who undergo mechanical thrombectomy and look at their serum glucose levels, and again, the serum glucose levels in these trials was not controlled on a pre-specified protocol. It was whatever the institutional protocol was. The patients who actually have high glucose or high serum glucose, and then the threshold of defining high serum glucose can vary between institutions and studies. But nonetheless, people or patients who have high serum glucose, when they undergo mechanical thrombectomy, appear to be at higher risk for post-treatment intracerebral hemorrhage, and also a higher rate of death or disability. And there are some pathological reasons for that. I think that high glucose actually worsens ischemic injury through a variety of pathways. So I think that, there is some biological rationale to support that high glucose levels actually may worsen cerebral ischemia. So the question then becomes is that, well, if you reduce glucose aggressively, can you actually reduce the ischemic injury and perhaps actually have a low rate of death or disability? So there is no specific trial that has been done that has actually randomized patients with mechanical thrombectomy to a very rigorous glucose control versus a less rigorous glucose control. So we actually looked at a clinical trial that had done that with acute ischemic stroke patients, that included all acute ischemic stroke patients, including those who underwent endovascular treatment. And we only analyzed the patient that actually underwent endovascular treatment. So what that gave us was some patients actually were randomized to the intensive treatment group. So the serum glucose was really maintained at a very low level. And we're talking about somewhere around 110 milligram per deciliter. Or actually kept at a modest level. So we're talking somewhere between 140 and 180 milligram per deciliter. Now, granted that that's not the primary focus of the trial, so we are actually doing a post-hoc analysis, so obviously our sample size is reduced. But nonetheless, if you look at the rates of favorable outcome, there is no difference. So the patients who actually got randomized to intensive glucose control, the rates of favorable outcome were the same to those who were randomized to standard glucose control. So at least in this particular observation, we did not see a benefit of intensive glucose reduction or glucose control as compared to standard glucose control. And again, an ideal group have been no glucose control. So the comparator group should have been a no glucose control. But where our understanding is no glucose control is not considered a proper standard of care anymore. So the practical implications are the standard protocol that we are using are appropriate, and additional or more rigorous glucose control will not increase the rate of functional independence or reduce the rate of death or disability.